Welcome, Monica and Miranda. We really look forward to your presentation, and let's do our thing.
All right. Well, thank you so much for the invitation. We appreciate being here. So as you know, we're going to talk about approaching research with a health equity lens. And so we'll get into some terminology in a moment. So we can go ahead and advance to the next slide.
All right, no disclosures. So what we, since so much of who we are is influenced by where we came from, and that and where we come from informs, and influences so much of the work that we do, we thought we would begin this talk by giving you all an idea of who we are. Just a little bit of description about myself. I'm the daughter of South Asian immigrants. My parents both grew up in rural North India from socioeconomically disadvantaged backgrounds. My father is the son of rice farmers, and he was the first in his family to pursue higher education. He actually, he planted his US roots right here in Washington, DC, and enrolled for a master's in electrical engineering at Howard, and supported himself through school through taxi driving and being a busboy in one of the local hotels here in Washington, DC. My mom was the first in her town to go to medical school. And then I was born and raised in New Jersey. And then I went to college at Duke University. I spent my early 20s trying to get rid of my very thick New Jersey accent, which I hope I succeeded in doing. And then when I was at Duke, I became really involved in social justice issues on campus. Specifically, I ran a living wage campaign at our university, and that work really informed my interest in going into medicine and thinking about how I could apply some of my interests in social justice from a medical lens. So then actually I deferred medical school for a year, and I moved out to the Bay Area, where I worked as a community organizer around issues related to reproductive health and immigrant rights. And then I moved to Philadelphia to attend medical school, and then completed my pediatrics residency and a pediatric emergency medicine fellowship at Children's Hospital Philadelphia. And a lot of my interest in pursuing a career in pediatric emergency medicine stemmed from this desire to care for underserved populations. And now I live in Bethesda. I have a husband who is a translational researcher and a scientist at the NIH. And I am inspired every day by my two girls who are 7 and 11 years old. All right, Miranda, take it away.
And so I actually have Southern roots, with my daddy being from New Orleans and mama from Arkansas, migrated out west. So I was born and raised in Southern California, and a proud product of pipeline programming as I graduated from my high school's Medical Services Career Academy. And, I'm a first generation student, so I was the first to kind of go to college. And when I did decide to kind of drive across the country to go to a small liberal arts, historically Black college for women, yes, the illustrious Spelman College, that is when I learned that, I can have a health interest and not necessarily have to limit it to a clinical path, right? And so that means I don't necessarily have to pass chemistry, right? And so, to kind of keep my health interests intact. And I learned that through a mentor who introduced me to public health. And so I actually was, mentored by a public health giant, the late great Dr. Bill Jenkins, who started the Public Health Science Institute at Morehouse College right across the street. Took all the courses there, public health minor, basically was under his tutelage at the CDC, and then literally decided to pursue public particular maternal and child health for my graduate studies, what brought me even further south to Tulane, which is again where my dad's family is from in New Orleans. So so I really been studying kind of community health. That's where really I just felt most alive and was really kind of see the tangible outcomes of my work. So I was doing a lot of community-based work. So when I came to DC, first for a policy-based fellowship that I actually didn't enjoy, but I appreciated the opportunity. It really kind of furthered my conviction to kind of focus on community health work, and was basically designing a service learning curriculum for all the first-year medical students at Georgetown. And that's literally how I learned about the health landscape of DC and all of the structural inequities that are kind of, that we see from one neighborhood to the next, and placing them to work in clinics and advocacy-based organizations and community-based organizations. And I took that knowledge with me to the did at Children's National Medical Center, managing all of their adolescent prevention education programs. But it was at that point that I realized that, what? I have lots of practice-based experience in kind of curriculum development, program evaluation, but I would love to pair that with some formal training. So that's why I decided to actually come back to school and enter at GW and kind of, focus on a degree on in curriculum and instruction in the School of Ed. So as I was kind of doing through the whole dissertating process, I was teaching, from the School of Business to the School of Ed, and now here in the School of Medicine and Health Sciences. So literally I've been at GW for a decade. And so, yes, I'm an assistant professor in the Department of Clinical Research and Leadership, and I teach, undergraduate public health courses, but I continue to describe myself as a community educator because DC remains my classroom, right? So yes, I have community engaged courses, and, I have a youth, pipeline, youth development pipeline for DC youth that, literally pairs them with GW college students as their mentors, but also engages them in the pipeline programs that I also kind of take the lead on for our program. So we have a HRSA funded national program that we administer here at GW. And so it's just kind of serendipitous that it all kind of come full circle, right? I started off in, a pipeline program myself, and now here I am, working with first generation students from economic or educational disadvantage in my kind of professional role. And I will say that, one of the things that's been very useful for me during this, this pandemic is having my Shishan puppy, who's a mix between a Shih Tzu and a Bichon. So if you go to the next slide, Monika and I wanted to start with kind of sharing, our stories, because we know that our stories are, literally our upbringing, basically translate into our values and our worldview. And that literally shows up in our practice, it shows up in our teaching, and therefore it's definitely going to show up in our research. So you'll see that the questions here, we're going to kind of turn it over to you. And we're not inviting you to answer these questions now, but as a reflexive researcher, being prepared to take the time to go through the introspective exercise of actually thinking about, not does my biography, but in what ways does my biography show up in my research? And this is really important because, if you think about who we are as researchers, we have a lot of power. We're literally, determining, we're writing, contributing to the literature base and the evidence base. And this is going to determine what people think about, believe, and, about a particular phenomena or, socially disadvantaged populations, right? And so this is why, for example, just thinking about one of the 17 executive orders that was signed today was about, every federal agency needs to kind of scour their policies and look, and to determine in what ways is your policy basically either advancing racial equity, or is it, kind of, maintaining racial inequity, right? And similarly, we're going to have that very conversation today because there's no kind of race neutrality, right? It's not like, oh, well, I just do lab research and I'm do biomedical, kind of bench, science. And so that's someone else's role that does kind of social behavioral research. Absolutely not. All of our work most certainly impacts socially disadvantaged populations. And it's incumbent on us to really kind of be very clear at the outset of our research, thinking about just the line of inquiry itself, in what ways are we maintaining, basically these narratives around, social disadvantage and inequities that kind of come up in that, or in what ways are we dismantling it, right? We have to choose a side. And so if you're not intentional about doing it, then, then the impact is that you're maintaining it. So that's literally what we want to talk about, that opportunity to redistribute power. So if we go to the next slide, we'll see that literally what we want to do today is have that conversation about, yes, we talked about, okay, how do you integrate a health equity lens into your research? Well, we can't talk about health equity without talking about racial equity, because you're never going to achieve health equity without achieving racial equity, right? And the senior leaders across the medical enterprise, the GW enterprise, they get that, right? We've had a measurable commitment to health equity, and they, given the social political climate that we're in, they've been very clear that, what, we need to have just as much of a measurable and visible commitment to racial equity. The two work in tandem, so we're going to have that. You'll see that in our conversation today. So when we talk about equity, though, we're going to share some standards, right? Now, what are some ways that you can literally infuse an equity-based lens into your research? It's everything from the very line of inquiry, like the question itself, to the populations that you engage, to the methods you use, to the way you write and share your research, right? So we'll talk about all of that. And then ultimately, we want you to feel comfortable being able to defend why this is important, right? Again, no matter the type of research you do, you have a role, right? It's not left to someone else to take on the torch of leadership around this, right? We all have to think about how the ways in which our research kind of either furthers inequity or it disrupts it. So if we go to the next slide, I want us to have a conversation. Okay, so literally, I'm sure you've seen graphics like this in the aim to kind of explain what health equity looks like. So let's get 2 volunteers. So if one of you can actually share, in what ways are graphics like this really useful in aiding in your understanding of health equity? That would be, useful. And then I also want another volunteer to share in what ways are graphics like this kind of, what are the blind spots of graphics like this in kind of describing what health equity is, what's problematic, in what ways do graphics like this kind of miss the mark? So do we have 2 volunteers who'd like to jump in and share?
My name's Samantha Hamburger. I'll jump in. I am at Children's based in the Child Health Advocacy Institute. I think that it's really helpful to speak to your first point. It's helpful to have graphics like this just as a visual. I think that it kind of cuts across health literacy and helps communicate like a really complex topic in a way that is very digestible and engaging.
Okay, thank you so much for that, Samantha. You're right in that the intent behind graphics like this is to be very clear that, when we're talking about equity, we're not talking about equality. So the intent is to distinguish between these interrelated concepts, right? With equality being sameness and equity being fairness, right? So then, does anyone know in what ways that graphics like this actually miss the mark and really furthering an understanding about how to frame health equity? Lee? Oh, it says connecting to audio. I thought you had your hand up. Okay. Okay. Well, I'll just share how it definitely misses the mark. So if you look at this graphic, one of the first things that you probably might kind of tune into are the people, right? It's like, oh, look, we have a tall person, a, medium, average, height person, a short person. And so there's a tendency to interpret these type of graphics about, well, some people have what they need and have, the resources that they need, others don't, right? It's about kind of thinking about the capabilities of the inherent, ability of people. And that's the thing, when we're talking about equity, we're actually not talking about the innate or inherent, capabilities and or deficits of people. But when you look at graphics like this, there's a tendency for us to think that way, because it's kind of like, well, of course, this person can't do it, so they need help, right? So let's kind of give them what they need. And so, when we're talking about equity, we're really talking about is shifting the unit analysis away from people, because when we're talking about equity, we're talking about disparities, and disparities actually don't exist in people, they exist in populations. And so we have to actually focus on the conditions and the environment in which people live. live, right? So this is not about the individual characteristics of people and what they can or cannot do. This is about the conditions in which they live that provide unfair advantage and or barriers. Okay, so the type of graphics that are more useful to really frame an understanding of equity are the ones where the foundation is uneven, right? Because it's not about the people being taller, shorter, having more capabilities and things like that. It's about, you know, this person actually has a boost, right? AKA generational wealth, AKA unearned privilege, right? And these, you know, and this person, like all the people are like the, you know, like instead of having height differences, like just have different colors so we can still have diversity. But, you know, it's not about the differences in the people. Let's see like this, you know, this particular, you know, populations of people actually have barriers in place. So they're like further behind. And so it's like, it's almost about catching up, right? And so this is why we want to kind of start with an understanding of like, what are we even talking about when we say health equity? So if we go to the next slide, I do want to take some time to just frame the discussion.
All right, guys.
Happen to the slides, okay? Okay, so
Where are we?
Time to frame the discussion around health equity, because again, I want us to have some shared language in understanding that health equity is actually, okay, so health equity is actually a normative concept, right? It's a concept of what ought to be, right? So, you know, basically everyone should have a fair opportunity to achieve their fullest health potential. So it's about the opportunity for health, not individual decisions and responsibility, right? So that's kind of like, that's why the framing is really important. So we understand we're talking about opportunities for health. Therefore, we have to talk about conditions in which people live. So if we know that, then, okay, well, how do we determine, what is the metric for health equity? And the metric is health disparities. So if we want to know, like, okay, so where are we with our aim for health equity? Well, does health disparities exist? You know, so health disparities become the empirical concept, right? So health disparities are literally, you know, we're literally looking at incidence and prevalence of, you know, kind of disease and poor health outcomes, right? But it's not just any health difference, because health differences are naturally occurring. They're to be expected. They're going to be developmental differences. They're going to be genetic variability. There's going to be neurodiversity, right? So we're not talking about those type of, you know, inevitable health differences. We're talking about the unfair, avoidable, unnecessary ones, right? So those are the ones that exist among socially disadvantaged populations. So that is what a health disparity is. And so, but the thing is that it only tells you, you know, what those differences, those social differences are. It doesn't tell you why, right? And again, those differences are among socially disadvantaged populations. You can't explain them biologically or genetically. You can only explain them socially. So then if you want to know, well, how, like, you know, well, why do they exist? That's where the concept of a health inequity becomes really useful, because health inequity, what that really is exploring is, you know, the reason why there's going to be, you know, these unfair, you know, avoidable, you know, kind of differences that literally adversely and disproportionately impact, you know, socially disadvantaged populations, is because of things like historical trauma, trail of tears, slavery, research abuse, right? Things like segregation and poverty. And so like the big, large macro issues that are literally patterned across time and generations, that's what they call like historically disadvantaged populations, right? So they're not happenstance. They don't happen just a couple of people here and there, isolated events. No. These are structured and patterned across time. And literally, we literally have the evidence to show that it's happening again and again. So it's been designed, it's by design. And the only way to actually mitigate and address and upend those inequities is through social justice. So that becomes the how, right? And that's rooted in human rights principles of, you know, that's the policy that we talked about. Like, it's not a people issue, it's a policy issue. So it's policy changes like resource allocation, but it's also thinking about, you know, like changing attitudes and ideology. Okay, does everybody see this? Because I think my slide looks a little different. I'm not sure if you, like right now, I'm looking at a presentation mode slide.
You are? You're not seeing it. You're not seeing it as a.
So it's okay. Let's just go to the next slide, because I don't want to take up time.
All right.
So when we talk about, you know, disparities, ultimately what we're talking about is the structural and literal environmental drivers, right? The factors that are literally determining health outcomes, right? So, and when we say health outcomes, and we're talking about health status, we're talking about functionality, we're talking about quality of life, we're talking about healthcare expenditures, we're talking about how long you're gonna live, like morbidity and mortality, right? And all of those factors are everything from, you know, economic security and education to housing and transportation and food and, you know, and neighborhood and built environment, right? So these are the things that we're kind of talking about, and recognizing that, you know, it really kind of varies depending on social identity. So what we're going to do is now give an example of what that looks like.
Okay. So again, so how do disparities play out in healthcare? So I wanted to share some data from a study that we did a few years ago, where we looked at whether or not children with appendicitis had differential management of their pain. And this was a national study over a 10-year study period. And during that period, there were over 1 million children that were diagnosed with appendicitis in the emergency department. Of those children, only half received any analgesia. And as many of you know, analgesia is the mainstay of one of the mainstays for managing appendicitis. Appendicitis can be extremely painful. And then only a third received opioid analgesia. So then what we did was we looked at rates of analgesia administration by racial group. And what we found was that there were actually no racial differences in the overall use of analgesia between Black and white children, meaning that we were equally bad at providing pain medication to all children. But then we looked at the type of pain medication that was used. And it turned out that when we did actually use analgesia, we were more likely to treat pain in white children with opioids and treat pain in Black children with non-opioids, so medications like ibuprofen or acetaminophen. And then what we did was we stratified our analysis by pain score. So after adjusting for ethnicity and triage level, we found that in children with moderate pain, we were less likely to treat Black children with any type of analgesia whatsoever. And then when we looked at children with severe pain, we found that we were less likely to treat Black children with opioid analgesia. So in other words, in children with moderate pain, race contributed to whether or not a child received any type of analgesia at all. And then in children with severe pain, we were more likely to use medications like morphine and Dilaudid for our white patients, and medications like acetaminophen and ibuprofen for our Black patients. And so what this indicated was that there seemed to be a threshold effect in the use of pain medications overall, and then and in the use of opioids, and that threshold differed by race. So disparities in healthcare have been well documented and have received considerable attention over recent years. In 2002, the Institute of Medicine released a report called Unequal Treatment that documented significant variation in the delivery of healthcare quality by race and ethnicity, even after adjustment for insurance status, income, age, and severity of illness. And in this report, the IOM specifically addressed healthcare disparities, so meaning disparities in the quality of healthcare. And so this schematic here describes that definition. And so we've got quality of healthcare along the y-axis, and we see that the quality of healthcare is lower in minority populations compared to non-minority populations. And that difference is ascribed to clinical appropriateness and need and patient preferences, the operation of the healthcare system in legal and regulatory climate, and then discrimination. And it's the latter two that contribute to racial disparities that we see in healthcare. So how might we as clinicians be contributing to these disparities? There was a study conducted at the University of Virginia that examined whether racial bias was related to false beliefs about biological differences between Blacks and whites. And they administered a questionnaire that asked a battery of questions related to beliefs about differences between the two racial groups. And what they found was what they did was they actually surveyed white lay people through an online survey. And then they surveyed medical students and residents at University of Virginia. And so you can see, and this is what's so shocking to me, is that medical trainees, although they were less likely to endorse these false beliefs, almost 10% believed that Blacks' nerve endings were less sensitive than whites. And a third believed that Blacks' skin was thicker than whites. So remember, these are medical students and residents who are now attending physicians, right? And so this is just one example that demonstrates that we as healthcare providers are not immune to bias.
So to contextualize this conversation about racial bias, we have to first understand racism. And so when we talk about racism, yes, racism operates at many different levels: individual, interpersonal, institutional, right? But let's just be very clear that when we're talking about racism, we're talking about our ideologies or beliefs that are literally rooted in white supremacy. The idea that, white people are, inherently better. They are human and everyone else is not, right? It's a devaluing of anyone else who's not white. And we know that, these beliefs have been, literally they're kind of permeating the ways in which we're socialized. And, in this country, but literally worldwide. But let's just think about well, what does that look like, right? Like we think about the ways in which, history is told, right? The ways in which art, humanities and literature, kind of maintain these kind of narratives around kind of of whiteness, right? And then we, can take it specifically to, medicine and science. So let's give an example of what that looks like in medicine and science. If we go to the next slide, we can see that, science, literally has been used to kind of maintain these falsehoods. Literally, like this idea of race-based medicine has been kind of erroneously interpreted as evidence-based medicine. So, starting off with kind of measuring the brain circumference to say, oh, look, white people, they have bigger brains. So like they're smarter, more intelligent. And that literally was published as kind of medical findings and studies. And that has infiltrated the kind of public sphere. So then you wonder dinner table conversations and policies, it stems from credible, at the time, which has obviously since been debunked, research and, and scientific studies. And so this is why we have to have these conversations about the role that medicine and research and science has actually played in reinforcing and maintaining these falsehoods and literally these racist ideas. So for example, when we talk about the idea of white supremacy, which is the idea that, white people are to be higherly, more value, have, more social kind of power and ranking. And then therefore everyone else is devalued and othered. We see it play out in so many ways. So if we just think about, the federal government literally commissioning a study to literally study the untreated effects of syphilis in Black men, right? And they did it for 4 decades. So that's a very, widely coordinated, study to basically, pinpoint a group of, Black men who were sharecroppers who couldn't read and write, so they couldn't consent in that way. And they literally relied on the of community health workers and nurses who the federal government kind of said, oh, look, let's work with them again. So a lot of the things that we're going to talk about today is how do you expand and reach the populations? They were using some of the very, kind of evidence-based tools that we say, these are the ways that you reach populations. They were doing that, working with community health workers and nurses, but they were doing it in ways that were perpetuating these ideas that, Black bodies were, disposable, right? To be used for purposes of research. And they literally lied to them and told them they had bad blood instead of actually diagnosing them with syphilis, and then lied again and said, we're going to treat you. But they actually were, assessing what happens to the body if it goes untreated. And literally, that's why we know that syphilis comes in 3 stages, and can lead to neurological damage and blindness, because they studied it in all of these kind of cohorts of men. And so, but just think about what that means, right? To literally have these men kind of go around, thank you for that suggestion, Taha, about the book, right? Because this book right here is definitely incredibly important. And so is this book here. Let me take this off a bookshelf. There's another book called Medical Apartheid. I'm not sure if you can see my screen, but this is another really great book. It's a dense read, but definitely worthwhile. Another one called Just Medicine is also by one of our the dean of our law school, Dana Matthew Bowens. So, but the thing is that the devaluing of Black bodies is evident, right? And this is commissioned by the government, right? So even when penicillin became available and they could treat it, they denied treatment. And when men moved around, like they coordinated the effort to ensure like, do not treat them because we wanted to see what happens. So not only is it racist and unethical, right? It's just unconscionable. But again, this is not limited, right? So just think about the impact that we talked about, historical inequities. This is an example of like, why we have disparities, because this is an example of a historical, inequity, right? This is historical trauma. And then, what happened with the immortal cell line of Henrietta Lacks, a Black woman who went to Johns Hopkins, medicine, for treatment for cervical cancer. She died, but they used her cell line. And so the book that I mentioned is the one that's here, The Immortal Life of Henrietta Lacks, and the other one is here. And again, I'm not sure if you can see my screen because I can't see you. Okay, there it is. It's this book here. It's called Medical Apartheid. And so, yeah, this is a really good one. And then so is Just Medicine. Just Medicine is right here. Just Medicine is another one. So there it is. Okay, perfect. So basically, if you go to the next slide.
So the slides better. Can you see them now?
I can. Yes, definitely better. Thank you.
Okay. Sorry about that.
So then this is the thing though, again, racism is rampant throughout medicine, right? So we just think about, for example, I know we're talking about, first of all, we're not just race, right? We live at the intersections of our identities. We also have to think about what it means to also be a, not just a racial ethnic minority, but a sexual minority, and what that means, right? For like ongoing disparities in care. But if we were specifically to talk about Black women in particular, let's think about the maternal health crisis that we're in now, right? The US has the highest, like the highest rate of maternal mortality than any other industrialized nation. And in particular, among Black women, right? And the rate is astronomically high, specifically in DC, right? Literally, Black women are 3 to 4 more times likely to die giving childbirth than any other woman. And if you think about it, you can take a Black woman from Botswana, a Black woman from Haiti, a Black woman from London, have them come to the US and have their baby, and they fare well. So, but it's the Black woman that was born in the US that does not fare well, is more likely to die. So we know it's history, right? Because we can look across the African diaspora. So what is it about specifically about being a Black woman in America? Right? So that's like literally the field of epigenetics, looking at that kind of, carrying that generational trauma and passing it down generationally to the point where your body can't undergo the stress of labor, right? And then not to mention couple that is convoluted by provider bias and, not, again, this kind of historical trauma of not trusting in the medical, research, right? Not being able to see providers that look like you, and then not to mention the legal challenges and not being able to have different access points of the way that our bodies are politicized. So if you go to the next slide, AMA made a historical, in a historical move, they have named, and rightfully so, finally, racism as a threat to public health. And this is incredibly important because not only does it, not just because of, the social political moment that we're in, no, beyond that, I mean, the nation is kind of having this reckoning, but that the AMA, as you know, is an authority, in medical education, the medical field. So this also is allowing them to turn the mirror on themselves and actually reckon with their own racist past. Like J. Marion Sims, who was the picture on the previous slide was of, the father of modern gynecology, literally was perfecting his gynecological procedures and tools and like the speculum and things like that through unethical experiments on Black women, right? Enslaved Black women who obviously can't consent because they're enslaved. And then he was doing it without anesthesia because of the racist ideologies that Black women, they can endure pain because, there's the idea that either we're subhuman or we're superhuman, right? So, so again, it's racist, it's unethical, right? And he was one of the former presidents of AMA. Right. So the AMA has most certainly maintained racism and, again, like I said, race-based medicine. So we'll talk a little bit more about some of the kind of the statements that have been made and like the magnitude of that for what that means for research in a minute.
So sadly, racism is still prevalent in healthcare, and we see this with respect to access to care, use of care, and quality of care. And for those of you that are familiar with the story of Dr. Susan Moore, even being a physician, having money, education, and the ability to advocate herself did not prevent her or protect her from dying from racism. And as some of you may know, Children's National, in an effort to increase access to testing very early on in the pandemic for children who were suspected of having COVID-19, we set up the first site, the first drive-through walk-up testing site exclusively for children in the United States. And over a 5-month period, we ended up testing 2,500 children through this testing site that was located at Trinity University. And what we did was we reviewed data from the first 1,000 children that were tested to measure disparities in COVID-19 infection rates. And so what these figures show are just the racial ethnic composition of the patient or the children that accessed our testing site. And you can see that there was a lot of racial and ethnic diversity with respect to who accessed our testing site from the pie graph. And then the map that we show also gives you an idea of the fact that people traveled really long distances to access this testing site. And this is just a hallmark of the fact that early in the pandemic, it was very hard for children to get access to testing, and we provided a large community service. What the graph also, or what this map also shows, is just the median family income of the patients that were accessing our testing site. And so again, the different shades of green represent different median family income quartiles. And again, you can see that the patients that were accessing the testing site had a lot of socioeconomic diversity. So overall, of those 1,000 children that, the first 1,000 children that came to our testing site, 20%, so 1 in 5 of those children ended up testing positive for COVID-19. And what we saw was that those positivity rates really varied by race and ethnicity. So where you had about 7% of non-Hispanic white children testing positive for infection, 30% of our Black children were testing positive, and almost 50% of Hispanic children were testing positive. And then when we adjusted for age, sex, and median family income, you can see by the graph or the table that our Black children had a 2 times higher likelihood of testing positive for infection, and Hispanic children had 6 times higher likelihood of testing positive for infection compared to white children. So then we conducted similar analyses based on socioeconomic status using median family income. And here what we did was we divided our patients into 4 equal groups by income level. And we found that 8.7% of children in the highest income quartile ended up testing positive for infection, and those positivity rates increased substantially as income level decreased, with 37.7% of children in the lowest income quartile testing positive for infection. And then these associations remained even after multivariable adjustment. All right, Miranda.
So if we think about, okay, so thank you so much. So we just had an overview of kind of like, okay, putting racial disparities in context to COVID, but then we know that going back to the science of things, right, there's been a push to really kind of, focus on coming up with this vaccine and thinking about the kind of regulatory kind of climate around that and the science behind it, right? But it was at the expense of the education around it, right? So it's kind of like, this goes back to our earlier comment around, there's this idea that, well, no, I just do clinical bench science research, right? I don't need to kind of care about or be concerned with these issues. Absolutely, you do. And this is an example of why. Like, just focusing on the science of things, ultimately the science is for the purpose of literally furthering what we know, advancing the field, protecting the health of the public, right? And so you focus so much on the science that you become ahistorical, right? And don't contextualize the meanings and the impact that this vaccine and people's, hesitancy to engage in research because of the very things we talked about, like historical, like research abuse, that, now we see like, oh, well, the uptake of the vaccine has actually been, historically low, right? And unexpectedly low, right? And then the thing is, we started off with, now that we have a new administration, we we actually have a national plan around COVID, but up until this point, we hadn't had one. And so we just had these priority populations with healthcare workers being one of them. And literally the Kaiser Foundation and, health departments are literally reporting low uptake, right? Literally like less than 40% of healthcare workers were actually taking it. So it's kind of like, we haven't even gotten to the general population yet. And these are people who believe in science. So like, it's not about the science. It's about all of the other things that we're talking about. So we have to have conversations around equity. If we go to the next slide, the NIH, they recognize that. They said, okay, you know what? Okay, we understand clinical research is biased toward old white men. That's who sign up for clinical research. And you know what? Let's go ahead and put together a All of Us campaign where we, as you can see with this graphic, we want to have diversity, come on and join our, join clinical research. But again, it still misses the mark because it's not enough to just say, join this research, just like it's not enough to say, take the COVID vaccine, right? Where is the education? Where is the reconciliation? Where is the, okay, you know what? We need to repair these relationships. We need to restructure the way we think about research with historically marginalized population. So if we go to the next slide, I want to just pose the question, so I want to know, does anyone actually use race in your current research? And if so, how are you using it, or how are you thinking about using it?
Come on, guys, we know some of you, or at least some of you, if not all of you, are using race in your research.
Absolutely, because that's one of the demographics that I know that you're collecting. So let's talk about it.
My name is Bryn Marks. I'm one of the endocrinologists, and we actually have in type 1 diabetes, there are some horrific disparities in terms of outcomes. So I'm actually in the process of launching a study, taking the kids that according to statistics are least likely to get access to the latest diabetes technologies, so advanced insulin pumps that help with blood sugar management. And for the purposes of this study, we are trying to design a targeted educational curriculum and to give these kids access to the same technologies that other members of the community are using in hopes of showing equal outcomes so that we can further that goal.
Yeah, thank you for that. So thank you so much for sharing that. And this is all, it's like intervention-based research. I'd love to hear that, right? So it's like you're literally like providing an intervention within the research. And so, disaggregating by race is important. And we recognize that, often race is used as a proxy for racism, which is why we wanted to pose this question, right? Because what we're doing is, going back to the AMA statement and what we just know is that, there is no biological basis to race, right? So the AMA in that statement, they have, been very clear. Like, let's discontinue to use race as a biological determinant, right? Remember, ever since we completed the human genome, we literally have mapped the whole genome. And we cannot trace race because it doesn't exist biologically. Race is made up, okay? So therefore, what we're really looking at, if we see differences, is racism. That's literally what we're looking at, right? If we're not like actually looking at ancestry, which that's like a separate conversation. But race in and of itself is, again, really you're looking at the ways in which people have opportunity structured differently, AKA racism. So if we go to the next slide.
This one? Or you want to go to the next one?
If we go to the next slide,
yeah.
Then and then we'll talk about what does that look like in research. So it's important to build those partnerships. So if we go to the next slide, we can think about, okay, you know what, we talked about, it's really important for us to think about engaging communities, just like Bryn mentioned, like, you know what, I realize that this population really, again, historically has been denied or disinvested when it comes to this particular opportunity, for health. So, you can, as a researcher, define, the research problem, which is the traditional way when we think about research, like, okay, here's the issue, and then here's the population that I want to work with, and then that becomes you doing, research, on that population. So one of the things that we're, offering as another way to kind of, think about research is, yes, I realize that sometimes your research kind of starts with your funding, your grant. So like, oh, but this is what the grantor or the funder is looking for. So that's why I had to define the population. Recognize that participation does exist on the spectrum. So there's more than one way to kind of engage community throughout the process. So you could start with, let's start with the community and they identify what their priorities are, because that's one of the things that happens when you as a researcher determine what the priority is or what the problem is, and you go into community and there's resistance and or you're wondering why people aren't signing up. It's kind of like, well, that's not high on their like priority list. So had you, started with actually what we really want to know about and talk about and get, resources, around is this. And then you would have had a lot of people kind of sign up. So for those reasons, there's that. But beyond that, recognizing that we're going back to that, the importance of shared power, right? When you're engaging with community, there's investment and there's a reciprocity there. So it's not just helicopter research where you're swooping in, gathering data, going back to the ivory tower, to the hospital and kind of writing it up. And so it's kind of like, no, it's kind of like, well, what am I going to get out of this as a community member, right? How is my life different? How is the work of the organization going to be improved, right? So that's why we have to think in different ways where communities need to actually be able to own the data, like co-own it with you, co-own the narrative, co-create knowledge, right? Because that's like what we're doing as researchers. So if you go to the next slide, this is about, thinking about, okay, so what exactly am I even asking, because you really think about, okay, I mean, in all research, you have to be very specific. We know that, right? But in doing that, there's something that you're not asking, right? So, and again, it's always, going back to being that reflexive researcher, it's just going to be helpful to kind of log that, like journal that. And I will say, I went to a workshop last week, I think. It was last week. So Dr. Terry Kine, she led a workshop for the Academy of Education Scholars around narrative medicine. And more journals are actually interested in these type of conversations, like the subjectivities around research, right? So again, for those of you who are like, well, I'm doing gold standard objective research, there's no such thing actually as pure objectivity. I know that's the aim, but you are human. So you chose that question and that population and you've interpreted the data, like all of that is subjective, right? I could have asked something else. So log that, write about that, right? Who am I, if I'm going to work with clinic X, and so that's going to be the population that I'm including, right? And then of course for your IRB, you have an exclusion criteria. We're not talking about that when we say who are you excluding. We're saying when you are including a population, technically, who you're excluding, if you know anything about the community, is whoever doesn't access, that particular clinic, right? So if I'm working in this clinic, people who don't go there because they can't access it, they can't afford it, they're not part of the target, catchment group, that's who you're excluding, inadvertently. So like, these are the types of questions that we want you to consider. So if you think about like who, I need to be a little bit more deliberate and intentional about my research. If you go to the next slide, there's a tendency also for us to think about, oh, well, there's these, hard to reach groups, right? And so we have that kind of that thought that, when we think about historically disadvantaged populations, one of the things, there's many kind of cross-cutting things that like what makes them, socially disadvantaged. Again, that disadvantage is not inherent or biological, it's social, right? But where does that social disadvantage come from? One of them comes from the idea that these are populations that are consistently overlooked, silenced, discounted, undervalued, right? And again, it comes up across in policy, practice, and research. So do we really want our research to actually further marginalized populations because because you're characterizing them as hard to reach? No, you just need to take the time on the front end to do the legwork to establish partnerships. And, I want to recruit, women to, assess their psychosocial needs during pregnancy, right? Okay, so then literally establish partnerships with, organizations that serve all types of women, right? Not what's convenient or, oh, I got a partnership with them, so it's just easy. It's not, we're not in the business of doing what's easy. We're doing what's necessary. That's how we move the needle, right? So if we go to the next slide. If it goes to the, okay, so then that's where, identifying partners becomes really incredible, right? Because then it takes the onus off of you to start from scratch, because those communities, they already serve, groups. So like they can also, that's one of the benefits of like kind of that relationship, like the communities in which they serve becomes a community that you can actually engage in the research. And again, like I said, really have that kind of shared power. And there's so many ways to do that, from community advisory boards to, actually kind of thinking about the process, engaging communities and throughout the entire research process, and even kind of thinking about the ways that the data is going to be used. And we'll talk about that when we get to dissemination. But if we go to the next slide, an example of what that looks like is, so the University of Maryland, they actually recognize this, right? So it's like, they have this innovation design studio on biomedical clinical trials. And they say, we recognize that we need to partner with community anchors. And in the Black community anchors are barbershops and beauty salons, right? So that relationship that, that clients have with their barber, with their stylist is unparalleled. So let's do that. Let's go into the, barbershop and literally get haircuts, hang out, get to know the, the barbers, get their trust, and then tell them about this research. And then they will therefore, kind of transfer and engage people. And then people will start to join the research study, right? So this is just an example of so many. And by the way, one of the things that I'm working on with, with like Patrick and things like that, this team is putting together like a virtual organizer to think about our research and ways that we can think about health equity. So all of these resources will be made available to you. So if we move on, I know Monika's going to move on to how to broaden your representation.
Yeah. So, typically when we design research studies, our goal is to try to enroll patients as quickly as possible, right? And so oftentimes what ends up happening is that those study participants end up being those that are, easy to contact, easy to enroll, easy to follow up, are adherent to treatment. But those populations then may not always be the patients that are typically underrepresented in research. And so it's really important that when we are designing our studies, that we're thinking about strategies to enroll patients so that they're more representative of the patients with whom we're ultimately trying to be impacted by our work, right? And so one way to do this is to enroll populations in proportion to what is representative of the degree of health disparity. Alternatively, could design studies that contain large proportions of where you're targeting disadvantaged populations, and that's what leads to scientific equity. And then, when we really want to think about reach from study inception, so not after the study's completed. And I think this is kind of one of those mistakes that oftentimes researchers make. And you want to think about how broad implementation often overlooks the importance of unique contextual factors that may perpetuate healthcare inequities. So as all of you are familiar with, there's persistent and stark underrepresentation of vulnerable populations in clinical trials that inform evidence-based interventions. And so this leads to threats to our external validity of our studies. And this is why it's really important that studies mirror the context where vulnerable populations are served and live. And so ways to kind of address this from the beginning is to, again, increase enrollment and engagement of vulnerable populations. And oftentimes that's through stakeholder engagement, and to really think about broadening your settings and communities where you're conducting your studies. So oftentimes we use large data sets to address health disparities. I shared with you how we have used large data sets to measure disparities, right? Like in terms of, analgesic use for children with appendicitis. Oftentimes large data sets can be used to explain disparities. So for example, hospitals that have live interpreters, like at, in the emergency department, have higher rates of analgesic use than hospitals that don't have interpreters present in the emergency department. You can also use it to address impact, right? So, through the development of quality improvement and a quality improvement initiative, we showed that disparities in pain management were mitigated. Another way is through, or one interesting and novel way to address disparities is through agent-based modeling, which I'm definitely not an expert in, but I have been reading a lot about, which is basically a method of building computational models that will simulate complex systems and can incorporate in not only individual attitudes and health behaviors, but also social determinants of health. And so some of that research is now on the horizon, and I think it's a really novel way to measure disparities. And so here, I just wanted to share this graph with you to provide an example of why it's so important to consider health equity from study inception. So this graph is basically a screenshot I took from a study that showed how a health system had developed a risk algorithm tool that to predict complex healthcare needs for the purpose of targeting interventions to manage those needs. And what they did was they basically developed this algorithm to using cost of care as a proxy for health needs. And what they ended up finding was that because providers spend less money when they care for Black patients, as you can see from this graph, so, Black patients are in purple and white patients are in yellow. Black patients required more chronic conditions to be assigned to the same risk category as white patients. So, so what this algorithm was doing was it was predicting lower healthcare needs for sicker Black patients when compared to healthier white patients. All right, so now we're going to move on to implementation. And I don't know how many people in the audience are implementation scientists, but implementation science is really the study of the use of strategies to adopt and integrate evidence-based health interventions into clinical and community settings to improve patient outcomes and improve population health. And so it focuses on how to apply research advances in real-world systems. And
wait, I'm sorry, Monica. Let me just note, because it's now 12:59. So
oh boy,
we actually started 5 minutes late. So for those of you who can, stick around for another 5 minutes, so we have the full 60 minutes, you're more than welcome. But if you have to hop off, we understand.
Yes, thank you for that. So, when you're designing a study, it's really important to look at it through a participant's lens and have an implementation perspective to your intervention development. Which again is not something we're very good at doing. And the reason for that is, again, because you could have designed the best study, right? But if you can't implement it, then it's going to go nowhere. And so it's really important to try to think about placing implementation outcome at the forefront of your development process, and to also incorporate user-centered designs and community-based participatory approaches to do that. So, and then additional ways to kind of address issues related to health equity are to focus. So what you can do is you can focus exclusively on populations that are experiencing inequities. And this is really important when you're trying to improve outcomes in communities with low opportunity. And so one way to do this is you can scale up, and scaling up means expanding the reach of an evidence-based intervention to similar settings and populations in which it was tested. And then there's also this concept of scaling out, where you're basically adapting evidence-based interventions to new populations. And so adaptation, basically, when you are adapting an intervention, you're paying attention to those contextual factors that are influencing or perpetuating healthcare inequities. And so when you do this, you want to be really systematic and be guided by by your theoretical framework. And then you also want to be really systematic in how you're tracking and identifying adaptation across different contexts and populations. So just kind of almost like from a QI perspective, like doing a lot of audit and feedback. And then again, we've been talking a lot about kind of using an equity lens for implementation outcomes. So again, ways to do this are, we really need more descriptive and explanatory studies to identify those factors that are contributing to inequities and implementation outcomes. And we want to be conducting more studies to develop, test, and refine those implementation strategies to achieve equity in outcomes. And so that's really where, we've been doing a lot of the descriptive work and kind of identifying and measuring disparities. Now where the work really needs to go is explaining why those disparities exist. I think many of us, we've discussed what those causes are, and then really doing the work to develop those interventions to eradicate disparities.
And so now it comes to, you have to disseminate your findings. And so if we go up to the next slide, it's really important to not use coded language, literally just say what you mean, right? Not use euphemisms like people of color if you're really just talking about, Black patients, right? Humanize the patient populations instead of saying homeless, patients, like, okay, patients experiencing homelessness. And again, really kind of like to have that intersectional lens and really kind of look for within. If you go to the next slide, this is where thinking beyond the academic journal is important. Yes, of course, we want to publish in an academic journal, but we also want to, make sure that our, this important work actually gets to the communities and, that it's impacting. So these are just some examples of ways that we can do that. If you go to the next slide, we don't necessarily, we have like 2 minutes left. And so I'm not sure, Monika, if you want to just stop here or like just summarize like the standards, but maybe we can also open it up just in case there are questions.
I think stop here, and what we can do is we'll just circulate this article that was in Health Affairs that really kind of established standards for researchers, journal editors, and reviewers about about how we should be talking about race in our research studies. And so maybe what we'll do, Patrick, if you don't mind, maybe we'll just have you send out this this article to everyone that attended, and now we can just open it up to questions. Does that work?
You bet.
Yes. I know someone in the chat wanted the full citation of the McNulty citation for like one of the other standards. Are there any other questions or any other challenges that are there any challenges that any of you are, experiencing or perceive in kind of, bringing these standards and integrating these standards into your work? Absolutely, the presentation is going to be made available. So, so Patrick already has a copy of it, so he can go ahead and share that widely. And then, we'll also send the full citation from McNulty as well as the last article, the Health Affairs article. Any other questions we can answer? All right. Well, we're at our time, so.
Thank you, everybody.
Thank you so much. I will say the very last thing is on the very last slide, there's our contact information as well as an invitation to join the Anti-Racism Coalition. Like I said, the senior leaders across the GW Medical Enterprise, have created this Anti-Racism Coalition, and I'm actually taking the lead on the education kind of, the education and program development arm of that initiative. So if you'd like to learn more, be engaged in our work, attend our ongoing kind of webinar series, you can email antiracistgw@gwu.edu. You can also email me directly because my email is below. So thank you so much for the opportunity to have this conversation with you today.
And I also want to remind everybody that on the children's website are specific committees that are related to our DEI initiatives, many of which are linked to the Anti-Racism Coalition. So please take a look and see if any of the community, education, or communication subcommittees are something that you might want to be involved in. Thank you so much, Monika and Miranda. This was wonderful. And everybody have a very good day.
Thank you. Enjoy. Bye.